is my current position. I'm a consultant nephrologist in Southern Royal Hospital, just under 15 years. And today's topic is acute kidney injury in COVID-19. Some of the slides I need to acknowledge are borrowed from the American Society of Nephrology and also some of the collaborators from Vicenza in Italy who have had early experience of acute kidney injury in COVID-19. So we'll set the scene first. Everybody's familiar with some of the background, but just to set the scene so we're on the same page. New condition relatively, wide variability of symptoms and illnesses. We will show that the lungs are not the only organ that is affected. Wide variety of organ failures are reported in the ICU. And there's a combination of distant and local effects of the virus itself. Some neurohormonal, some direct invasion, some other effects as well, such as cardiovascular instability. We'll touch a little bit on that. And we'll touch a little bit on the hemostasis mechanisms that may go awry or change during this condition. This is not a particular talk about the condition, but some of the manifestations of it. You are all familiar, I hope, with the changing nature of this condition. This is a coronavirus. This is the phylum of coronavirus, as you can see on the virology. And this is their reputed, at the moment, theory that it is a transmission. A zoonotic event has occurred between two hosts, and in this case, it's the bat, and then into the intermediate, which is this particular animal everybody now familiar with, the pangolin, and then into the human population. This is not unusual. It's happened a number of times before, and those in my field will be familiar with other infections, such as SARS and MERS, that's happened in the Middle East and the Far East. And at times, this is the first one that's really affected the West in a big way. So other countries have dealt with this, and they have better systems dealing with it than we have. It's affected us because of heparin use in the past is also affected by these conditions. Okay, so let's jump straight in here. On my daily basis of working, when we look at acute kidney injury, at the severe end, those needing renal replacement therapy before COVID, so this is a term we're going to look at, BC, before COVID, we're looking on the ICU, and we're looking at almost, in certain series, about 13% on ICUs need renal replacement therapy. And you can see the different stages, and we'll define those for those who are not familiar with the Kyogo stages of acute kidney injury, and stage 3 being the severe, and out of those, stage 3, about 13.5% need renal replacement therapy, and we'll touch on the different varieties of renal replacement therapy. We obviously know that acute kidney injury is associated with a mortality, and then with the series and with the changing nature, during COVID, 6 to 10% of confirmed cases have required ICU admission, so not all patients being admitted to hospital require ICU, and a significant number have acute kidney injury, and in certain series, up to 30% required renal replacement therapy. So you can see it's a tenfold increase in the number of patients needing renal replacement therapy. And these are global figures. There's huge variation. So, and we don't understand why that is the case, from originally in Wuhan, right down to Italy, and then to the UK models, we're finding different prevalence and incidence of AKI. So it's very difficult to define it, saying it's unanimously, this is the rate. AKI in the particular hospitalized patient with COVID-19, as I said, the frequency is unclear. Early reports, such as in China, showed very little, so we're talking less than 1%. Italy showed very high numbers, so up to 40% in ICU required AKI treatment, and then 20% needed renal replacement therapy. Hence, there's a capacity and demand issue that occurred in the West that didn't occur in the Far East. And then there's multiple published and unpublished data. So if I look at the local data, so the UK data, if we home in on this number here, which we collect through the ICU network called ICNARC data sets, that reported 17% at the beginning. So we're talking about beginning of March, going into April, and then it's dropped right down now to a lower number. It's due to case mix, type of patients being taken on. So there's multiple co-founders to exactly say if the rate is the same, but ICNARC data is showing about 17%. And then similar with these figures here. So As to what happens to the natural progression of the disease, so what happens after AKI, we'll touch on a little bit about that, and we'll define what I mean by AKI, what I mean by CKD, and what I mean by the interim, which is AKD, a new term that's coming in. Having said that, at the basic level, we're going to start with KDIGO, and this is the definition we now use for acute kidney injury. And we're going to touch on what you can do on the ward level, let alone what you can do in the ICU level, and how you can define these populations. So first definition, and hopefully the audience is familiar with this kind of definition. So this is what we call AKI, now defined by the Kidney Disease Collaborative, the Global Collaborative, and this is the definitions of the 3 stages of AKI. So we have stage 1, 2, and 3. Remember, you can have AKI with a normal creatinine, so it's just looking at variations. And then if AKI goes beyond 90 days and doesn't recover, and you need ongoing either renal replacement therapy or the renal function has not returned to normal, we call it CKD. So that's just a definition. So what happens in between those 2 time points? Well, if we go beyond 7 days and before 90 days, we've got this term called AKD. Just a way of defining, it doesn't mean the disease has changed, but it helps in nomenclature and helps in research. So these are the terms we will use: AKI, AKD, and CKD. Now, jumping into AKI. Acute kidney injury, you will be all familiar with the mechanism of pre-renal, intrinsic renal, and post-renal. What about COVID? Well, COVID is a condition that affects many of those areas, pre-renal and intrinsic renal. It doesn't cause obstructive uropathy, but it does cause these. So the mechanisms, we believe, in broad terms, there's element of hypovolemia, and we've learned the hard way actually, because originally in the first few months, everybody thought these patients would be fluid overloaded. And that was based on people worried about ARDS, and there was protocols coming out of China at that point talking about resuscitation, but volume limited resuscitation. So we got element of hypovolemia. And this is probably true because majority, one of the main symptoms is fever, and the insensible losses are significant. And sometimes people have diarrhea as well. So volume loss, if anything, most of these patients are volume deplete, not volume overloaded. And locally in the UK and where we work in the Northeast and internationally, that wasn't the case first. People thought they were volume overloaded, and there was a lot of use of diuretics. There's an element of ATN, which is damage to the tubules in the kidney, then leading on to classical acute kidney injury. Now, how that happens, we're not sure. This term cytokine storm has been used, and also there's something about severe hypoxia affecting the kidney as well. Then there is now reports coming through direct invasion. So this is now intrinsic renal disease. So these are mainly pre-renal. This element is intrinsic renal. And there's evidence both from pathology specimens, post-mortem specimens, electron microscopy, and light microscopy, where the virus particle and the RNA is seen within the kidney itself, co-localizing with infection. And then there's the states of overall, or what we call organ crosstalk. So when one organ is affected, another one is affected, and in the cytokine storm and sepsis, you get multiple organs being affected, and perfusion pressures of organs are reduced. And therefore, you may have a reduced perfusion pressure of the kidney in the state of septic shock or cardiogenic shock or right ventricular failure. And then I will touch slightly on the ACE2 receptor. It's not my field, but I'm sure there's immunology talks coming, I think tomorrow. We'll touch on this a little bit more. But it's interesting, the prevalence of the ACE2 receptor in certain organs and not in other organs. So that may affect how organs are affected. So those are the broad areas how kidneys are affected by this particular coronavirus. Practice, since this condition has now been prevalent since about December, has shown us also there's a coagulopathy. And we've learned that from when we dialyze individuals that we have to use higher doses of anticoagulants. And therefore societies have come up with such parameters regarding VTE and PE assessments. Those working in COVID wards would have seen a higher prevalence of PE disease. In this country, we've had a variance of using CTs, but actually we've seen more and more of PE disease as well. So looking at that in particular, there are now protocols to anticoagulate people based on their risk. And this is one particular protocol from Emory Healthcare, which is in the States. And what it looks at is the different levels of risk of having a deep vein thrombosis, and then using low molecular weight heparin accordingly. So and it's based on the parameters that you would check in the COVID patients, apart from the normal blood panels, the series of LDH, D-dimer, troponin, CRP, maybe ESR, LDH. But when you assess these individuals, you can then risk stratify them into levels of risk. Now, if people have previously had VTE disease, then that increases their risk. But if you've got a raised D-dimer, that increases your risk. And therefore, using a low molecular weight heparin. Now, these are guidelines from Emory. There are similar guidelines in the UK from the British Thoracic Society, again, looking at low molecular weight heparin, and then moving on post-discharge of these patients, because some of them will, obviously, majority will be well to go home, to using a DOAC as well. And we can touch on that if questions come up. These protocols exist. They are still changing. And national guidance, as I say, in the UK is from the BTS, and this is the American guidance. So what do we do? Well, AKI is no different from the early manifestations. Early manifestations is good assessment. So clinical examination, volume assessment, really homing in on that using traditional methods of clinical examination, but also moving in to use other methodologies. And I'll touch slightly on point of care ultrasound to do that as well, and fast scans that you can use to assess for volume. But it's important that we do so because the sweet point, not volume overloaded or underloaded, i.e. volume deplete, is important to help support the patient to get through the acute kidney injury. And this is what we talk about, this sweet point. So remember, a lot of these patients, if anything, they're coming in hypovolemic, not volume overload as we originally thought. So they may have respiratory symptoms, and classically of the COVID variety with diabasal crepitations, there'll be hypoxia, and to differentiate that from fluid overload sometimes it's difficult, and therefore people thought they were fluid overloaded and they were having diuretic therapy. But this ambient losses from fever, volume losses from diarrhea, nausea, vomiting, and hyperventilation per se as well. So this is prodromal prior to coming into the hospital. We find a lot of them requiring, if anything, volume resuscitation. And it's trying to get euvolemia. And it's difficult. Clinically, you'll get euvolemia right in 50% of the cases we do clinical examination. So how can we improve that and try to go along this management? We can't put central lines in everyone. We can do basic examination, and we can look at observations, so capillary refill, basal crepitations, JVP, vital statistics such as BP, heart rate, SpO2, urine output monitoring, which I'm a great fan of, but it's not done very well. And then this new challenge of using ultrasound. And I'm in particular favor of this. It's coming. It's easily now available by the bedside. And there are some protocols that exist from the Faculty of Ultrasound that tell you how to use ultrasound to assess volume status. So the devices are available. This particular one we've used in our trust called Acute. And here are some training models that are available to in certain institutes that you can use that help you understand and train yourself and your juniors how to assess patients' volume status. And it's done by the bedside. It is in conjunction with the classical methods of clinical examination, chest x-ray is shown to be very effective. Okay, so that tells you a little bit about the volume status and the AKI. We'll move basically on to the epidemiology. Now, everybody else is probably familiar with the two top symptoms of this COVID-19, fever and cough, but there's many others that we look out for, myalgia and fatigue and general tiredness. And then obviously on the lab parameters, we're familiar with the lymphopenia. The history is straightforward. The chest X-ray examinations are straightforward. There's some high-risk groups that you need to find out in the history. And we'll touch on the, I think we're going to touch on the cardiovascular risk, but the three big groups are diabetes, hypertension, and cardiovascular disease. And it's important we recognize that because they have a prognostic effect as well once you get COVID later down the line. And that puts you into a more higher risk group itself. Fine, so you know the protocols exist of presenting these patients and what they look like. We then go on to define it a little bit more. And this is where I have the difficulty of saying, what is your AKI risk on a standard COVID patient? Well, the series, and these are the series that exist as of March 2020, mainly out of Wuhan, and there's some out of the US. And you can see the renal replacement rate, highly variable. You've got one center going 22% needing renal replacement, and the other going 5.2, averaging out of 5.8. As I say, in the UK, it's 17, but the confounders are, in many of these series were known dialysis patients were counted in these series. So we just need to be careful of that, to quote somebody with that. Having said that, if you have AKI, you end up in the ICU. Your outcome, so cumulative incidence of AKI, you're more likely to have AKI if you have ARDS. Now that's a condition that is being talked about a lot in these patients. So if the patient is deteriorating with higher flow oxygen requirements from the general medical ward and they end up in ICU and they have element of ARDS, and the ARDS is, I'm not going to define that, it's not my area, but it's not classical ARDS that we're familiar with. But we know that AKI goes with ARDS. So here is a cumulative plot time over days, and those with ARDS are more likely to get AKI. So it usually goes hand in hand. And other findings from these series, I'm just going to highlight. You may notice myoglobinuria, rhabdomyolysis, proteinuria, and hematuria. And that's interesting because these can be defined at the ward level. You don't need a fancy test. A urine dipstick will pick up proteinuria, hematuria. So that may give you an effect of something's happening in the kidney before the serum creatinine is returned from the laboratory. So a simple urine dipstick and a blood test will pick up majority of these findings. And the prevalence is significant. So almost 44% in a series here are proteinuria, and 26% had hematuria. And another series was 26% with hematuria. So it's something that a nephrologist go on about. Dipstick in the urine will give you a lot of information very quickly, and especially so in the COVID patient. And does it matter? Why do we want to know? Well, in this particular series of 710 patients, if you had these three factors, so very simple factors, serum creatinine, dipstick proteinuria, dipstick hematuria, then the hazard ratio of increased risk of dying was all positive. So AKI stages were 2 and 3 more common if you had these three findings. Elevated blood urea or serum creatinine more common, and also hazard ratio of 3+ of proteinuria or 2 to 3+ of proteinuria. All give you increased hazard ratio above 1, and therefore is a way of defining a population better. And I'm sure the speakers will talk about defining that population, because majority don't go to the ICU, but you need to know which one will need to go to the ICU. So pathophysiology. AKI, this is, there's many models of AKI. This is pre-COVID. So don't forget about all the other nephrotoxic insults that can occur. In this particular case, mechanical ventilation and ARDS and sepsis and immune function will be affected. But all these others, ischemic reperfusion, nephrotoxic, CKD, cardiorenal, are all classical and not specific to COVID. These other factors will be specific to ICU patients as well who are having sepsis. So that is ongoing. And then on top of this, we have this picture. So the coronavirus itself, RNA virus, has spike proteins everybody's now familiar with. Spike protein is then attached to the receptor, or the ACE2, and there's a transmembrane protein that affects this coupling effect. And then the endocytosis occurs, and then the viral RNA in this case is used to then create more copies. So I'm not a virologist, but that's a simple replication event that occurs in different organs. And this question is where it works and it's controlled, and somebody has COVID and clears the virus, and where it becomes uncontrolled and you get multi-organ failure. Why does that occur is the question, and nobody really knows at this moment. We're discovering this ACE2. Remember early on, we remember the panic early on through the social media about ACE inhibition and using ACE2, so drugs such as ARBs and ACE inhibitors. A lot of the societies have come out to say that we shouldn't be stopping those drugs prophylactically in high-risk populations such as diabetics, hypertensive, or cardiovascular disease. The jury is out regarding if you are more susceptible to COVID-19 if you are on these medications. We just don't know the answer right now. So etiology, we've touched a little bit on fluid balance. interaction ARD-AKI, we've talked about that. We're saying that it's worse if you have ARDS, you're more likely to get AKI. We're now going to talk a little bit about these four areas: cytokine storm, direct viral cell toxicity, rhabdomyolysis, hypercoagulability. This is a busy slide. This is from Nature, probably last month. Again, similar. You get, in this case, we're concentrating on the airway, but it's similar in other organs. You know the droplet manifestations of the condition and how it's spread. The endocytosis we looked at. But what we expect normally to happen, that happens and the viral replication occurs. There's a normal immune response here. But then some individuals have a dysregulated response and lead to this picture, which is leaky capillaries and also, in this case, leaky alveoli. Or in this condition where you have a regulated response, a natural immune response is T cells and B cells, and you have antibody production, and then the virus is cleared through normal mechanisms. The question is, why does this happen? It doesn't happen in majority of the patients, it happens in the minority, but this pathway where it diverges in an individual, no, it is the key question in my mind, and that can be in many organs, and I'm going to concentrate now on the kidneys and how that similar pattern occurs. One interesting factor is those trying to look at this susceptibility model, why these particular patients have a dysregulated immune response. I've gone back and looked at the ACE2 protein. So the ACE2 protein is a bit on your respiratory epithelium, is in the kidney, is in the bowel, is in many other organs. And its frequency is different. So that's all I'm going to say. The frequency is not the same in all populations. Does this then give us a signal to highlight that in certain populations are more vulnerable than the others? That question is yet to be answered, but we know there is a difference in the frequency of that receptor. So moving on to my area, we've touched on how the particular virus is endocytosed in. It is then, subsequent to that, we have this particular picture of a cytokine storm. And from there, we have an effect. We touched on rhabdomyolysis, so there's myalgia, which is in keeping with that. So there's damage in the muscles. There's also direct inflammation within the kidney, and we'll define the podocythemia and the collapsing glomerulopathies. For this field, basically means intrinsic renal damage, and we can show evidence of that. And then indirectly through microangiopathy, not only probably to the kidney, but to the heart as well, and to the lungs, proving the point that you increase risk of maybe a P in the lung or a cardiac manifestation in the heart, or in the kidney, we might have internal thrombosis in the capillary blood vessels as well. So multiple factors through this particular paradigm are occurring that affects the kidney in this case. And from Claudio Ronco's work in Vicenza, this is the model we are now thinking is occurring. So we've got the virus, we've got the hypovolemia, we've talked about that. Hypercoagulability, direct or indirect, either direct through, we got element of myocardial dysfunction and then end organ perfusion pressure to the kidney. Direct effect on heart, the lungs itself called pneumonitis, leading to hypovolemia or ARDS affecting the kidney itself. And then through the mechanism of cytokine storm, endothelial damage, which in this case could be the capillary blood vessels in the kidney as well. So when we talk about AKI in the kidney, we talk about pre-renal and intrinsic renal manifesting through this current model that we are. Now, this is only a model. Professor Vincenzi is known for his models, so we'll see how this transpires over the next few months as we get to know this condition better. But how can we then, when you've got this model, affect and effectively treat the patient? Well, effectively treating the patients, what you want to do is prevent this model going out of control and ending up in death or ARDS. And we've touched on this already, where the dysregulation of the T cells or antibodies in the immune system itself is occurring. So along this pathway, we need to disrupt it. And I'm going to concentrate on this pathway. So how dialysis, renal replacement therapy, is organ support and organ treatment. And I use those words carefully because normally dialysis is supportive. We don't affect treatment that much, but we can use it in different modalities for treatment. So treating of the cytokine storm, let's define that a little bit. This is just a a picture, a cartoon explaining what I mean by that. You have a timeline, you have an organ that's injured, you have a threshold of pro-inflammatory cytokines and then anti-inflammatory cytokines to control that mechanism. The organ can be any organ. Well, I'll concentrate on the kidney in this case. And it is this pro-inflammatory cytokine milieu of usually interleukins, which are then counter-regulated in most individuals to control the cytokine storm so it doesn't go out of control and cause local and distant damage to other organs as well. And there's a recovery period. So that's just a classical model. This is what I mean in definition. So it's an activation of the immune system with extreme release of cytokines. What are these cytokines? Well, these are activated T and B cells, endothelial cells, macrophages, dendritic cells, all the cells that we're familiar with in the immune system and the endothelial system, releasing these cytokines. So when we talk about cytokines, this is what we mean, just to define those. The most famous one is IL-6. IL-6 is, you will see, is the one that is upstream of CRP. So you measure CRP all the time. Well, this is driven by IL-6, which is driven by the cytokine storm in mild or moderate or severe. And these particular molecules are very small. And I particularly say that because when we come on to dialysis, it'll define what we do on dialysis. So these are the models people are looking at regarding when we talk cytokine storm. And the storm occurs from the injury of the particular organ. Usually it's endotoxic, i.e. from a bacterial infection, but in this case, a viral infection. And here, there appears to be both direct injury as well as part of multi-organ failure, that renal failure occurs. I will not concentrate on the acute lung injury or shock and altered coagulation. Other speakers will like to touch on that. But in here, the cytokine storm does affect the kidney. IL-6 is the main sort of player here, causing the cytokine storm, producer B and T cells. So you'll see now lots of research coming through affecting B and T cells, affecting IL-6. Cause of increased IL-6 production, usually you can get it in severe infections. So you can get it in a bacterial infection with endotoxins causing it, or both in pulmonary and non-pulmonary sepsis. Triggers, here we have a trigger of let's say in this case is the virus, but why do some people produce more cytokine storm than others? Why do people have a bigger response than others? There is a variation, which then affects the outcome. Nobody knows why there is a variation. And that storm leads to these symptoms, which are those symptoms that we talked about right at the beginning. Fever, cough, shortness of breath, myalgia, arthralgia, and fatigue. And you can measure that with biomarkers that we normally use. Okay, and these are easily available in your laboratories. You can then use these biomarkers, i.e. albumin, CRP, ESR, LDH, and ferritin, to say that they correlate with the symptoms and they correlate with the cytokine storm. And then you can then measure them over time, of course, to then prognosticate if somebody needs ICU or not. I'll move on, though. Those are just a summary of what I've said. So here's the sort of main slide. So you've got a patient you think is having a cytokine storm because they're deteriorating, end of the bed, increasing oxygen requirements, fever, cough, temperature, CRP is going up, troponin, not troponin, but troponin may be going up as well. But PCT, procalcitonin, is another biomarker we use, and it's not familiar with everyone. It's another biomarker we use, and usually that is low, while all the others are high. We then move through this paradigm. We have different types of dialysis machines, and that's where we come into it, to help where the patient is in the response. If the patient is in the early phase from an endotoxin response from a normal bacterial infection, or in the middle phase where they've got a cytokine storm occurring, we try to remove some of those cytokine molecules such as IL-6, or they're in the organ failure phase, and therefore we support that organ. So in our case, it's renal. You can support that with renal replacement therapies, different varieties. Yeah, you can also support many other organs, but I'll concentrate on this. Obviously, there's whole body support with ECMO, but again, we'll just talk about organ failure as well. So that depends when the patient is in this particular paradigm. So if we get now the problem is majority of this endotoxin shock is occurring on the ward. They're not in the ICU at that stage. And therefore, you're not going to be able to unless you spot that early. This phase here has to be defined on the biomedical sort of parameters that we touched on. And it is practiced in different parts of the world differently, but they're not all available. So these are different types of filters we use. And then the filters we use at the end for support are different as well. So let's talk about that. Here's the model again. You get a viral infection, you get pneumonitis, and at that stage, the storm goes up. You get the systemic inflammatory response with the T cells and B cells releasing the interleukins. At this stage, the patient is deteriorating onto the ventilator. And that will classically occur, and then you might get endothelial damage and shock and affecting the different organs, so liver, heart, and kidney. If it is available to you, then at the stage of ventilation, mechanical ventilation, if the patient deteriorates enough, you may do whole body support with extracorporeal membrane oxygenation therapies, and ECMO has been used nationally and internationally. But we're in the phase of this particular cytokine storm. You can use different parameters, and I'll leave it at that. Different types of dialysis, continuous therapies, either called hemoperfusion or continuous renal replacement therapy, not only to remove urea, the classical models of dialysis, water and urea and electrolytes, that's what we normally do, but here to remove the cytokine storm interleukins. And you can either absorb them or you can filter them. And that therefore may reduce endothelial, cause some protection and reduce organ support later on. So Vicenza in Italy, Claudio Ronco is a big proponent of this. Around the world, the USA and down in London, we've been big proponent of this. The issue with this, using this treatment, is capacity and demand. Demand goes up tenfold. These are expensive, continuous treatments. So when somebody goes on this, they're on it continuously. Therefore, nursing resource, ICU resource, bed capacity all comes into it. The hemoperfusion is used on a twice daily basis, or usually, and the CRRT is just continuous. So 24 hours, every 24 hours, we will do that. So that, I'm not saying it's standard practice. It is used, it has shown some benefit. Particularly where we are in Sunderland, we use a form of continuous therapy called slow, low efficient dialysis, and we do up to 12 hours at a time. Our filters will remove the normal toxins such as urea and phosphate and electrolyte balance and fluid balance, and will remove some of the cytokines, but not all of them, because the patients are usually very unstable. They're tube ventilated, prone, and therefore also on inotropic support as well. I'm now going to change shift. What is the evidence? That's all about neurohormonal mechanisms, immunological mechanisms. What is the directive evidence that, in this case, the kidney is affected? Well, autopsy and pathology specimens. Here's a case of 26 patients, post-mortem examination, average age 69, 35% of that dipstick proteinuria and AKI. And we saw evidence of thrombus within the kidney. So this is this particular infographic here. This is a glomerulus. These are tubules, just to inform the audience. And then you get damage within the glomerulus, and you can see that damage. You can ischemic collapse, you get all the other findings as well. You get this is particularly what we're looking at, ATN, where the tubule is completely damaged. For the audience, what I'm trying to say, you get two types of damage. You get damage within the glomerulus due to the coagulopathy, and you get damage within the tubule due to ATN. So you can see that in the same picture as well. And as it heals, you see the normal tubular epithelium, and then starts to reform. So you can see these cells here compared to the flat base cells here. These are more taller columnar cells. So we see that picture occurring in the same kidney. And then if you look in higher magnification on electron microscopy, you can see the virus particles. So this is direct effect. This is endocytosis of the virus particle. You can see here occurring within the tubular epithelium and then into the glomerulus itself. So we've got evidence now of the cytokine storm having its effect, but we have this evidence of direct effect as well, both in the proximal tubule and in the glomerulus and the podocyte as well. And then you can then co-localize, and this is very interesting, the ACE2 receptor. It is also seen in the proximal tubule, just like it's seen in the lung and it is seen in the bowel. We can type the ACE2 receptor, and here are cells in the proximal tubule, and they're lighting up for ACE2. And what we see is co-localization of RNA in this case, which co-localizes with the ACE2 receptor and other antibody proteins. So giving direct effect that the virus is being endocytosed into the proximal tubular cells. So that's direct injury. And it causes many different effects. And this is another case of collapsing glomerulopathy. You don't need to know that, but it causes this proteinuria and vacuolation. And so that's how you spot them on the urine dipstick. This is what's occurring intrinsically to the kidney. And then again, high definition electron microscopy, you can see the actual virus particles within the podocyte itself, which is around the glomerulus. So I think we've got concluding evidence now there's a direct effect of the virus within the kidney itself. Now, moving away from that a little bit, this is a multi-organ disease. I'm concentrating really on the kidneys here, but there are many other effects, and I think the other speakers will touch on these, such as the heart and the neurohormone and the brain effect, but they're not indistinct. The cytokine storm is not specific to one organ. It occurs across all the different organs, and we need to be cognizant and aware of that as well. So, last bit of the talk, general management. So that's fine, we've defined it, we looked at the etiology a little bit. How do we manage it? Well, a lot of the management is supportive and no different to what you do normally in acute kidney injury. It's a very busy slide, and it just talks about what you do in the different stages. Where you got the history and examination, urine dipstick, I will highlight it before. Look at the variables. Kidney biopsy we rarely do. It's usually done in the recovery phase if people are not recovering. Please be cognizant and aware of nephrotoxics, optimizing hemodynamics with fluid management assessment, and be alert to other medications that may interact at that point. So it's worth discussing with your pharmacist, discussing with the nephrologist. Antibiotics are the classical one. So you may be using antibiotics to treat the individual who's got the sepsis, but in itself, they can cause tubular interstitial nephritis. And then looking out for the side effects of just acidosis and hyperkalemia. So a hyperkalemia management protocol should exist in your hospitals. And then use of bicarbonate, usually we use quite decent amounts of bicarbonate in these patients. And that's where the concern occurs because of risk of fluid overload. And I alluded to earlier that actually these patients are volume depleted rather than overloaded. And if you're getting to use bicarbonate and have hyperkalemia, you need to start discussing the cases with your nephrologist, because these are the cases that may then need the renal replacement therapy, either before ICU or on ICU. So those managements are no different. On top of this is usually sepsis management, again with the set protocols. And KDIGO similarly looked at the 3 stages which we defined earlier. Just to highlight some of the important things, apart from contrast agents. So this is the point that arises. If you're going to CT your patients looking for pulmonary embolic disease due to the coagulopathy, you may want to be just aware of their renal function at the time and use protective mechanisms to reduce the risk of contrast-induced nephropathy on top of their COVID-associated AKI. And then obviously when the patient deteriorates, then there's ICU admissions and requiring a renal replacement therapy. This is just another little bugbear. We've used jugular lines, subclavian lines are less used now in the UK, but it may be the case around the world that people are still using subclavian lines. They just have an increased risk of thrombosis, and that's why we don't like using them. So we move on to the last bit, fluid balance we touched on. Modality and selection. This is a very specialized area for renal replacement therapy. I told you about the different dialysis that are available. The anticoagulation, we've touched on really. Standards of practice for fluid management. This is the next bit I want to talk about really before we finish. So classically what we find, by the time a nephrologist comes to see the patient is being resuscitated in the ED or the emergency department. They have some maintenance fluids. We usually come at this stage and we're really struggling to remove fluid. So you know the classical patient, that what models of care you have is volume depletion is looked at in many other areas such as surgical or in the ED, and volume resuscitation is important, but the right amount. Over time, the patient usually becomes volume overloaded, and that's the main thing we struggle with when the patient needs renal replacement therapy. So fluid restrictive and diuretic use needs to be cautious. We need to go back to a volume assessment and considering renal replacement therapy to maintain volume status. So hyperkalemia acidosis is one indication, but volume depletion or overload may be another indication for starting renal replacement therapy. And we know if the patient is volume overloaded, as in this case, so fluid accumulation, survival, and recovery of kidney function in critically ill patients. If you have a fluid overload, this is a Kaplan-Meier curve, and you can see their survival is worse. So we want to optimize the fluid overload. So no fluid overload, the outcome is better, cumulative on the Kaplan-Meier curve, and similar on this graph as well. This is old data from 2009, and it's still pertinent now, almost 20 years later. Is there any difference for acute kidney injury management in the case of COVID-19? Well, the main thing is overrely on fluid restrictive strategies. In March, that's what we were saying to people: be careful of fluid overloading them. By May, we're saying no, actually, they're volume deplete. And if anything, you need to give them the right amount of volume to get them euvolemic. And that's because of the factors I've talked about, such as fever, intravascular dehydration, which is what we call third space. You might use this word where you get leaky organs instead of, such as the lungs and also the bowel. There you get third space of fluid loss and the patient's intravascularly deplete. And hypercoagulability, reducing the end organ perfusion of oxygenated blood. So this is what we've learned from March to May in this condition. So now we're saying ensure adequate volume status, gradual net fluid removal. And if you're getting into this stage, so the bottom line, it is easier for a nephrologist or intensivist to have a patient fluid overloaded and then having to remove fluid gradually over the next few days on ICU than having somebody volume depleted, third space volume loss, and then requiring inotropic support. It's better to have it that way around, where we can then start using our techniques of removing fluid. Now, just to touch on the renal replacement therapy, so information to the audience. Renal replacement therapy during ICU surge. So this is the increase in demand we expected at the time, that we have to increase our demand for renal replacement therapy in different models. So that was the background. We're expecting ICU patients will increase needing renal replacement therapy, and we have to look at what's available. So everybody's used different models of renal replacement therapy depending on capacity and demand. And in Sunderland, we used, as I said, slow or low efficiency dialysis or sustained low efficiency dialysis. And these are the models we look at. And around the world and locally, we have continuous therapies and we have intermittent therapies and everything in between, which is where we are. And when we also have this other therapy called peritoneal dialysis, and that has been used when capacity demand was an issue in this country, where patients were done for acute dialysis, they had a peritoneal dialysis placed. Again, all these are done in the intensive care or on the nephrology ward. As general physicians, we'd expect people to refer those patients in, usually with a classical issue of hyperkalemia, either fluid overload, uremia, or arrhythmias from acidosis. So these are classical indications for needing renal replacement therapy, which then we go on to, you look at the different therapies that are available. Now, each institute have different ones available to them. So it really depends on local circumstances and capacity. This is again in a little bit more detail, just to give you an idea. The continuous therapies are 24 hours. The intermittent therapies are 3 to 4 hours. And then in between, you can have 6 to 8 hours or 10 to 12 hours of non-stop treatment within the intensive care unit. All of them require good vascular access. And in these patients who are extremely sick, then vascular access is important. You'll be familiar with proning these patients. So we've had to think about how you can prone a patient, tubed, ventilated, and on dialysis therapy, renal replacement therapy. So yes, we've had experience used to prone patients before, but now to do it in a big way, we've had to think carefully not to. So we've learned neck lines and other lines get dislodged, so arterial lines and jugular lines get dislodged when you prone somebody for 12 hours. So the classical position is the patient is prone for 12 hours, they're on a ventilator, they're on inotropes, and they're on a renal replacement therapy, either combination of CRRT or hemoabsorption, so 2 dialysis. So you may have about 4 nurses looking after one individual, all looking at the different machines that are being used. So it is complex. Outcomes of these are variable though. And why do we want to do it? Well, we've touched on the cytokine storm and the suggested pathways and using different dialysis therapies. We've talked a little bit about organ crosstalk, so where one organ affects the other. I've talked about the systemic effects, which are positive fluid balance and using different therapies. And this just highlights on this infographic all the different types of therapies that we have available from cytokine storm, organ crosstalk, and systemic effects. I'm not going to dwell on it too much. So coming to the last couple of slides of the talk itself, I haven't touched on therapies themselves, apart from this particular area, cytokine removal and therapies, and using extracorporeal therapies such as renal replacement therapy as not only as a supportive treatment, but also as a treatment, not only supportive, but also as treatment. I haven't touched on direct therapies in the UK, these are all part of trials. Nobody's getting these medications outside trials, really. And then anticoagulation is the biggest thing we've learned. We've had to use a lot of anticoagulation on patients in the ICU or pre-ICU. And convalescent plasma therapy, I haven't touched on, but is again something in the future. In summary, rapidly growing knowledge related to COVID-19. We know it's highly transmissible, variable incident reported AKI and renal replacement therapy. Again, prophylaxis is the best treatment, volume management beforehand. And there's obviously the best way to move forward is put all these patients into trials. My last slide, take-home messages, one slide. Incidence variable across the world right now, as we talk of now, beginning of May, 0.5 to 23%. Those in ICU setting, 8.3% we now think is the figure. The need for renal replacement therapy is up to 9% in some of the series. What can you do at the ward level, apart from the normal blood parameters, where you can dip the urine to look for these parameters? This will really help you then identify the high-risk individual that may have increasing oxygen demand, may require renal replacement therapy, may require ICU. But if you know this in advance, that will be helpful. And then, of course, looking at the history, the comorbidities that we will touch on, hypertension, diabetes, CKD, and cardiovascular disease, all have an added risk factor associated with this. And I think that's probably, if we dwell on this slide, probably the most important one for the general audience. Thank you very much for your attention. I'm happy to take questions, whichever way they come.
Thank you very much, Dr. Saeed Ahmed. That was a fantastic and comprehensive talk on the renal presentations of COVID. I had one question really regarding the incidence of AKI, and you mentioned how there's such a wide variability in the reporting of incidence between 0.25% up to 25%. Yeah. Do you have any ideas why that is? Why there's such a wide variability?
There's a lot of co-founders. So we know the definition is KDIGO. So we have to use that definition in different audiences around the world. And we know from our experience in the UK, getting into ICU is variable. So because of how patients' comorbidities are looked at. Remember that I didn't look at outcomes from this. If you have ARDS and you have AKI, your outcome of mortality is very high, over 50%. So that then defines who you send into ICU in the first place. If you've got comorbidity, you've got poor prognostic markers and your outcome. So case selection, I think, is the main issue why you get variability of incidence around the world. People around the world have different case selections. The UK has a defined case selection. We're probably on the conservative side. Other countries have a generous case selection. In the early years in Wuhan, they had enough resource and capacity, but they had very few cases of AKI. And that's because the disease incident prevalence changed within 3 months, i.e. you had a spike of cases and then went down again, while others flattened their curve much slower. And therefore in Italy, they had a capacity and demand. They had a more generous case selection, and they needed a lot of renal replacement therapy and a lot of ventilators. In this country, we're somewhere in between. So I think that's how I answer that question.
Okay, thank you very much. Does anybody have any comments or questions that they'd like to ask Dr.
Thank you, Dr. Ahmed. I have just a few questions from the audience. And Dr. Saeed, do you mind if you can take your PowerPoint presentation off, then we can share the screen with the other speaker. Right, so the first question, Dr. Saeed, the question from the audience, they asking about would you recommend heparin just in patient with high D-dimer, or would you give like therapeutic heparin for any patient presented with COVID and AKI?
So we in the UK are following the BTS guidance on VTE, and they've just changed it recently, where people are getting low molecular weight heparin and then going on to a DOAC thereafter. But you have to define if they're a low, medium, or high risk. So anybody with a previous VTE and COVID will get anticoagulation, and they will get low molecular weight heparin, twice daily dosing, and thereafter go on to a DOAC up to a month of worth, even post discharge from the hospital. Those intermediate are based mainly on the D-dimer being raised, and those have normal D-dimer, they just get prophylactic. So you go from prophylactic, intermediate dosing, and then proper anticoagulation for up to a month. And that was the latest BTS guidance. It'll probably change again, but my point will be in the context of acute kidney injury, you have to then change the dosage according to their renal function.
Right, thank you. And the second question, sorry, Dr. Yagoub, for your comment. There's just a few questions from the audience, it's going to be very quick, I think. They're asking if the patient presented with respiratory symptom and then develop AKI, does that affect his prognosis, even if his AKI improved?
Yes, so it depends how quickly the AKI improves. If it stays in a state of AKI and then goes to AKD, i.e. it goes beyond 7 days and up to 30 days, then they'll have that might then relate in some level of CKD beyond 30 days as well. So that again will have a poor prognostic group in itself. Now, I have seen in our experience, we've had very little AKI needing renal replacement therapy overall due to case selection in the UK, especially in the Northeast. But we know I have 2 cases, AKI, renal replacement therapy on ICU tube, ventilated, the full works, recovered completely to come off renal replacement therapy, off the ventilator and discharged home. Now, we're not at the stage at the 30 days post-discharge yet. So once we get 30 days post-discharge, then we say that's somebody fully recovered. Now, they may stay in a state of CKD, but there are people surviving this. So this case selection business where you think individuals are not going to survive because of the high mortality, there are odd cases that do. And so that's why in certain countries, they will give everybody a go. Whereas others will say, no, 90% mortality age, this defined by the comorbidities is unlikely going to survive. And that is the difficulty of it all.
Thank you. And just last 2 questions. Can patient presenting only with simple AKI or UTI without any respiratory symptom?
Yeah, that is possible because you could get the glomerular intrinsic changes because we're not very good at dipsticking the urine, we're better at doing the blood tests. And you may have asymptomatic, i.e. You have no changes in the urea and creatinine at all, but you may have a positive urine sediment. So there are trials now ongoing to look at the glomerular effects of having AKI with normal renal function. So that's defined as asymptomatic, and these are changes within the normal range of your U&E, so they will not be defined on your laboratory parameters, but a GFR change will occur. How do you spot it? Well, if you dipstick the urine and there's blood and protein, they could have had an intrinsic AKI without a change in excretory function of serum creatinine. And therefore, what happens to those patients over time? Yes, they'll be in the mild group, but do they get CKD later on? We don't know because we don't look for those kind of patients right now.
I have a question, Abdalazeem. Abdalazeem.
Go ahead, Dr. Nasrein.
Yes. In the context of having both the ARDS and the acute kidney injury together, most probably the acute kidney injury could be related to the low, the restricted fluid balance in the case of ARDS. Once the patient is on the ventilator, so if increasing the fluid can lead to lessen the chances of developing AKI. So is this manageable through this pathway? So could we increase the fluid balance in the case of ARDS, and this can lead to reducing the incidence of AKI? So this is my question.
Yeah. So once the patient has ARDS, now the usual, proning the patients, and ICU intensivists always ask the nephrologist, dry them out. That's what they do. So we go and do a restrictive pattern of renal replacement therapy where we're taking fluid off. And I resist a little bit trying to get them euvolemic. Now, assessment of an ICU prone patient is difficult. You have a chest X-ray assessment, and that's all. You have obviously pulmonary, you can do pulmonary artery pressures. We've gone back to doing, many of you will know, wedge pressures, pulmonary artery pressures were hardly done.
Yes.
We used to stop doing them, but now we've gone back to doing them because we need to assess the volume status in somebody who's got leaky capillaries. So they're edematous on the outside. You'll see majority of the patients are edematous on the outside. They've got low albumin, all these kind of things. But what is their intravascular volume status? So can you use, echocardiography? Can you use ultrasound? Can you use a cardiac output status? Can you use pulmonary wedge pressures? So we've used all of these to really get those patients in a better euvolemic state. So they're not reliant on the ventilator as much as before. So you're absolutely right. You can, but you have to have a little bit more parameters than you normally do.
Well, in such a setting, sometimes I go for the tongue dehydration, where I see if the tongue is moist or not. So this gives me a clue if I cannot do a central venous pressure or a pulmonary wedge pressure. So could it help or?
Yeah,
Okay.
too moist is a very is an interesting test, but due to hyperventilation, anxiety, or the innovative, so if the patient is conscious, that is not usually a very good test of volume status. So I alluded to using the ultrasound machines, handheld. So if this is a patient conscious, i.e. not unconscious and ventilated, conscious patient, all in the ward or in the ICU, handheld devices will add to your clinical examination. So in addition to that, use those devices and you can look at IVC volume status, you can look at fluid in the lungs, you can look at pericardial effusions, all those kind of things. Again, those are through a trained mechanism for the person using it. I wouldn't want you to use it just because I've told you to. There are trained courses where you get yourself accredited to be able to recognize those findings.
Thank you. Dr. Junaid, do you want to add any comment or any question?
I'm sure Dr. Junaid will have some questions. I'll look forward to them.
Thank you very much, Saeed. As always, an extremely informative and detailed talk. I think you've kind of touched on almost all the organs, and I'm grateful you didn't go anywhere near the heart, which is great. That gives me something to do. Otherwise, I could have packed up and gone by now. No, I think the gist of what you're suggesting is that it is a multi-organ illness, number one. Number two, the mechanisms are still being looked at. Number three, that against our traditional learning and teaching, in COVID presentations, we seem to like accepting a slightly hypervolemic status better than a hypovolemic or a euvolemic status. Some of this might have to do with trying to have higher filling pressures for the right in a congested and soggy lung. In your practice, do you have a feel for the parameters that you would use on the ward, for example, clinical parameters that you would turn around? And I know you went into great detail around this, but just for a simple working clinician like myself, going into the ward, seeing somebody saying, I need Saeed to come in and sort this chap out with renal replacement treatment now. What would you want me as a clinician to be calling you for?
So yeah, thank you very much, Shahid. Great question. Over and above what we normally do in AKI, so the biochemical parameters aside, one of my big things is about daily weights. That's how you can tell somebody's getting fluid overloaded very easily. You don't need to be an expert in jugular venous pressure assessment or have a fancy ultrasound machine. I would want you to be able to tell me there is some element of diuretic resistance going on. So you've got a patient, you have brought to euvolemia, and now they're becoming volume overloaded, and two things: weight increase is occurring and there's diuretic resistance occurring. So what I mean by that, for the same dose that you start on diuretic on day one, you're not getting the same urine output, and therefore there's increased oxygen demand occurring. A combination maybe of the COVID findings on the lung plus fluid overload is occurring. That is the more common. The acidosis, hyperkalemia, and the uremia doesn't come that often. But for us, it is that, and that gets confused with the oxygen requirement from the interstitial lung disease that occurs with this, either pneumonitis. Yeah. So defining that, so how can you define that without, you put your stethoscope on the chest, you can do a chest x-ray, you can do a CT. But if you've got weight increase in day 3 of somebody's admission, and these are sick patients breathing a lot, they've got fever, they're not eating well, why is that weight increase occurring? It's not because they're eating too much, it's due to fluid overload occurring. And that's a crude but simple test. And it stood the test of time, because on average, a patient's admission, and we looked at this, most patients leave hospital heavier than they come in, despite not eating well whilst they're in hospital, due to the extra crystalloid that's given to them during resuscitation. And they never leave euvolemic. So that's what I would say to you from the end of the bed: assess the volume status, use the daily weight.
And one other very short and possibly final point for me. Can I ask you, in your sort of experience, which one of the therapies would you prefer in terms of renal replacement? And at the moment, I know this is evolving stuff, but is there evidence anywhere that suggests that one modality is better than the other? And what are our own survival rates?
So before COVID, our assumption was none of the therapies are better than the other. So using intermittent dialysis therapy, using continuous dialysis therapy is no different. During COVID, around the world, people are using all different therapies. No RCT is showing any difference. There's a lot of theoretical stuff that's happening. So Claudio Ronco from Vicenza would be a proponent of using hemoperfusion, absorption columns, and CRRT, and saying there's a better survival. He's never shown that. He's shown that it does work, but not in an RCT. And our outcomes are different because of our case selection. We've tried to take on the best cases we can. So those who are not getting into ICU because of comorbidities and activity of daily living, whatever assessments made, those are getting in. The outcomes are still being poor, 50% mortality in the therapy we have in Sunderland. The interesting thing, as you know, Shahid, we have 2 sites in Sunderland. And guess what? We have 2 different therapies. So the audit real time we're just undertaking, is the survival better between those? And that's a hot potato, because the case selection will be small. Case selection may be different, but our gut feeling is it is different. And I'm not going to say which one is better right now. Hot potato. But in the same center, which is unique. In the same center, we have different therapies. And when the audit comes by the end of May or into June, we will look at all the cases. It'll be small numbers, but we will just look at the case selection case by case and say, did one therapy do better than the other? We don't know, but I've got a gut feeling there is a difference.
Yeah, but I think that probably reflects selection bias, and I think that's what we've got at the moment. We're dealing with a pandemic situation in the absence of any randomized controlled trial data, with no specific disease-modifying therapy in hand, and there are groups of people as well as individual clinicians making clinical decisions and selecting patients for interventions or not, as the case may be, depending on resource availability and their own personal preferences and experience. And therefore, you will have a whole variety of not only treatments being given, but also results and outcomes being seen. So it'll be very interesting to look at the pooled data. As you know, we've already started an audit of across the region, course of patients and sort of accumulating clinical data as well as outcomes of their admission. And that will be interesting to see what is happening around the region. So no, just fantastic talk. Thank you very much. A lot of detail, but also very, very good practical guidance, which I think is certainly going to help me in my work. Thank you.
Thank you.
Thank you, Dr. Junaid. I got, sorry, we just a little bit running out of behind the time. I got one question regarding any role of plasmapheresis, Dr. Saeed, management of cytokine.
So in continuous therapies, which I alluded to in the cytokine storm, is hemoperfusion is the word we use. So plasmapheresis is a very crude way of just removing your plasma and replacing it. So we would use hemoperfusion as a cause. So it is used. Not in this country, again, in other parts of the world. No RCT evidence for its use, but if it's available to you, what we're trying to do is be selective in removing the interleukins and antibodies that may be affecting this condition. And the clever way of doing it is through absorption columns than plasma exchange. Plasma exchange is you remove your plasma and give some artificial plasma. The risk of that is that replacement plasma is antigenic. So these individuals then become having a lot of antigens given to them, have a response against that. So that is done in vasculitis, but not in this condition.
Thank you. I think that the question not related directly to the COVID-19, but might be, I think, very important, just to ask it quick. So a patient with hypernatremia, serum sodium 170, he had significant other comorbidities, and he had clear cause of leaking capillaries, and he is in fluid overload status. Any comments? How do I deal with this situation?
And they got AKI as well with the hypernatremia.
Not being asked, be mentioned here, but I believe might be there's a AKI at the same time also.
We find that challenge because that individual will end up needing renal replacement therapy to take the volume off, but we can't bring the sodium down too quickly, as you know. So we would modify our dialysis machines. We can change people's sodiums very quickly within hours, but we modify it to reduce the sodium over days to bring that down so they don't get cerebral edema, they don't get epilepsy or those kind of things that occur from cerebral edema itself as you bring down the sodium in this case. So I would expect that individual, if they weren't having AKI, they will have AKI and end up on the intensive care unit, and the nephrologist will then use the dialysis machine to help bring the sodium down slowly over the next 72 hours.
Thank you. And just last question, the question regarding patient in ITU in prone position in terms of access, renal replacement therapy. Do you have a specific?
Yeah, so the guidance now is right internal jugular vein should be the primary point to go for access. That's the safest. Femoral is difficult because obviously the patient's then prone, then you can't get access to the line. And lines are fallen out when people have been prone. So we just need to secure them well. Peritoneal dialysis, which is used in the abdomen, is pretty difficult to do when you prone somebody because you may improve the lung perfusion, but you increase the intra-abdominal pressure. And when the intra-abdominal pressure, then you can't get the fluid exchanges going. And therefore, it has been done, but you can't prone the patient then.
Thank you very much, Dr. Saeed. I think that is a very, very rich talk and a very, very nice presentation.